Good morning, everyone. I would like to welcome Sophie and Carina from Germany for your presentation. Well, enjoy.
Thank you. So, hi, welcome to our community talk, Fostering Fair Principles in Health Research, the NFTI for Health Journey with FIRE. NFTI for Health is a German project that we will present today. And my name is Sophie Klopfenstein. This is my colleague, Dr. Carina Vorisek. We are both medical doctors working at the Berlin Institute of Health at Charité. And we are both doing our fellowship in medical informatics within the core facility Digital Health and Interoperability. But let me quickly introduce you to NFTI for Health. So NFTI for Health stands for National Research Data Infrastructure for Personal Health Data. It's a German national project. We are an interdisciplinary consortium consisting of 70 co-applicants in entire Germany. And while the first phase will end next year, we are currently doing or applying for a new funding period of 5 years. The project focuses on data from clinical trials, epidemiological and public health studies. And we try also to foster requirements from these health research communities to foster collaboration between them. All the studies are either German studies or conducted at least one German site. And NFTI for Health proposes different opportunities and tools for the scientific use of the health data towards also fulfilling the requirements of FAIR principles. Among those services, we have, for example, blueprints and guidelines for data and metadata publication, data harmonization strategies, building local data hubs, but also the core of NFTI for Health, the Central Health Study Hub. The Central Health Study Hub permits to store metadata from studies from, as said, clinical trials, epidemiology, and public health. And is built upon different standards and formats such as clinical trials, the German clinical registry for studies, DataCite, etc. There are already such platforms doing something similar, but only for clinical trials, because clinical trials need to be registered, and that's not something that you need for public health or epidemiology. So this makes research not very efficient. You don't know what others might do or might plan, and you cannot reuse data or connect with other researchers. To do so, NFTI for Health developed a very generic metadata schema, as said, built upon different standards such as DataCite, clinical trials, etc. And we have the core module, which is on the top left side of the picture, which relates to all kinds of resources, meaning studies, questionnaires, documents such as study protocols, data dictionaries, registries, etc. In this module, you will find bibliographic information, identifiers, information about provenance or contributors. And then we have more specific modules which relates only to specific resources such as studies or registries, such as a design module where you can store the characteristic about the study. Was it interventional, non-interventional? Which population did you observe? Aspects about data sharing, interventions, arm groups, outcomes, etc. On the right side of the picture, you see more use case specific driven modules such as nutritional epidemiology and chronic diseases, which permits to those communities to store more precise data to fulfill their research needs, such as the method of how you collect your data, was it incident, prevalent, etc. And what we did was to represent the entire metadata schema in FIRE using FIRE shorthand. For each of the modules I just presented, we created logical models. We created also code systems among about 70 value sets, in total 19 profiles with quite a lot of extensions, 50 in total, where we always try to base them either on existing ones from R4 or to take R5 and do or construct backport extensions. We also provide instances as examples for our project and created our implementation guide, which you can find on Simplifier. You can just access also a Simplifier with a QR code, and all the artifacts are also on GitHub. And with that, I hand over to Carina for the methods and results.
Yeah, so Regarding the methods, once we receive all the content from the metadata schema group, we got rid of EXO files, which we are very proud of. So we're using a tool called Art Decor, which is an open source tool, and we can represent all content in there. It's like made for representing data sets. But you can not only represent the content, but also map to terminologies. And in here, you can even create value sets, local code systems, concept maps. And next to the content, you can also provide technical information. In Art Decor, that's called scenarios and actors. And in Fire, that will be cardinalities, conditions, conformances. And which is what is really nice about Art Decor is like you can export it as Fire JSON or XML. Then, of course, we need to make adaptations required for our NFDI for Health use case. So we transform the data into Fire shorthand, do all our adjustments, and finally compile with Sushi, and then validate with Happy. We used the VS Code extension CodeFSH, which was also presented last year at DevDays, and also work on GitHub. So doing version control and collaboration with our entire team, and finally publish our projects on Simplifier, which we mostly do in Germany. We add RHE, which we perform on Simplifier directly then. And now going into the Fire resources we're using, we decided to use composition as kind of like the base Fire resource, which is representing the core module. Why did we decide that? Well, the metadata schema entails many conditional cardinalities. So within the core module, depending on what resource type you're choosing, whether it's like a document or a questionnaire or a study or a registry, several different items are popping up in the metadata schema. And the same is like for certain information, whether it's provided or not, like items will be available or not. We did think about using a questionnaire with a structured data capture, but then ended up doing the composition because we also know that the evidence-based medicine group is currently working on profiles of composition representing research information. So this is how it works in our project. So we do have the composition resource, and then depending on what resource type is within the NFDI for Health resource, the subject is either referencing to document reference, questionnaire, library if it's a registry, or research study if it's a study or a sub-study. If there's information on nutritional epidemiology or chronic diseases, we do have a section then that is referencing to a profile for observation for nutritional epidemiology and on a profile for condition for chronic diseases, but that's optional. Within the metadata schema, we also have a lot of information on contributors. So also what are their roles? Is it personal? Is it an organization? What are their affiliations? Therefore, composition is referencing to author, via author to practitioner role, practitioner and organization. So we store that information in the composition Fire resource. There's also information on related artifacts that could be like outside of NFDI for Health, or could be another resource of NFDI for Health, but could also be like outside publications. So yeah, we use related artifact for library and research study here, and for document reference and questionnaire, we built an extension just resembling that information. There's also information on provenance, so when was it last updated, who was working on the NFDI resource, and that we're using the element agent referencing then to practitioner role and organization, and targeting then the equivalent resource, whether it's a document, a questionnaire, library, or research study. Because of the time, we're only going to look at one profile, so we chose the research study. Because it's our very biggest profile. You can see here we had to use plenty of extensions here, which is not nice. I can already see the faces, but we also have to remind that it's not only clinical trials or clinical studies, but it's like studies on public health and epidemiological studies, so it's very heterogeneous information here. So we do have further information on mortality data, or is it interventional, non-interventional, and then of course we had to represent our use case on record linkage, and as we're trying to promote the FAIR principles, we have the data sharing plan in here too. But whenever possible, we try to use backport extensions from R5, because we do have to say that from R5, like that research study resource is representing our use cases much better. We couldn't do it all the time because we also try to look at other German national big initiatives, like what they're doing. So we try to align with that too. And also Germany at the point is focused on R5. So we chose to use recruitment for representing eligibility criteria, referencing to our profiles on group eligibility, and then also information on the current population, which is represented in our profile of group actual. Another, like two more backboard extensions would be comparison group, where we store information on arms and interventions if it's an interventional study, or groups and exposures if it's an observational study. All this is an evidence variable. We also use outcome measure for title and type of outcomes and descriptions and timeframes. And in the end, this is what we end up with to represent our metadata schema. And for terminologies, I hand over to Sophie.
Yeah, as Carina already mentioned, we always try to map also all the values within the value sets to international or national terminologies. So in the beginning, we started with Normed and LONG and ICD for conditions, but we quickly noticed that it's not really matching our values, and so extended our search to other suitable terminologies such as NCI, UCUM, also ISO vocabularies or FIRE. But still, we ended up with more than half of local codes. One of the reasons is that the wordings might depend on the communities. So epidemiology and clinical trials might mean similar things, but like with other words. And yeah, that's why we have like many local codes which hinder data exchange and interoperability. So this is one of the biggest challenges we encountered. We also noticed that some terminologies might be suitable, but not really supported by FIRE yet. We have plenty of extensions, more than the 80-20 recommended, and that's like a pain point also for us. But we already noticed that developments within R5 and R4, especially for research study, might make those versions of FIRE better suitable for research study elements. But as Carina already said, Germany, or like major projects in Germany, are still using R4. As said, we have many local codes, so we will also try, or we strive to change them like to international terminologies, either by making content requests with relevant SEOs, rework the value sets, align them between the communities, also to make slices better usable in our project. And we encountered also problems with the validation of NCI codes within our project. We also didn't implement the project in a working system yet. So that's, I think, one of the biggest outlook. We want to implement it, but before that, we would also do some content changes of the metadata schema more towards a FIRE structure, so meaning aligning the value sets or also aligning the modeling of the elements or of the data types. We want to replace, as said, the local codes with international terminologies, and we want also to support more use cases and more requirements from the user community to maybe also implement it in future FIRE version via the working groups. And with that, I would like to end our quick presentation, open the floor for any questions, discussions, maybe also about your own experience within the health research field, the use of FIRE for the fostering of FAIR principles, or maybe also the use of the composition resource, because it's, I think, one of the biggest challenge we had also like in the last months. Thank you.
Thank you. A very good presentation. I work at Medical Affairs at Pfizer, and although you had a lot of extensions, I hope that leads to them becoming core resources in FHIR, because as I was watching this, and I don't know if my thought process is perfect or not, when you think about AI and wanting to create like we have the product label for medicinal products, we have a nutritional label for food products, could this help lead to more efficient processes to have that label for AI that we need in healthcare? Because there's a lot of people who are pushing for that and want to understand the studies behind it to make sure that we're creating all the responsible AI pillars or upholding the responsible AI pillars. So what are your thoughts on that?
So I think there are like many different strategies. There are like more general approaches, like having a general element or a general extension, like one fit for all, and using like different value sets and so on, or like more restrictive ones where you could say like, okay, this is my extension and this leads really like to this specific data and nothing else. And I think it's always like a balance, like depending on the project you're working on. But yeah, the way, like the more precise, the better. But it's always like an adjustment. And we try always like to take our requirements also like to the working groups, to exchange with other communities, to see like if it's, yeah, like how also like the community think about. But maybe you want to add something?
And the question was also about AI, right? Yeah. So I think that's like one of the key elements in FDI for Health. Like we're in the very, like not in the very beginning, we're still in the beginning, but we do want to make the data computable. And especially for epidemiological public health studies, it's a challenge because we do not have like those already existing major standards for these studies. And also a challenge for us is like on our side is like talking to the stakeholders, because for them it seems like it's also a new chapter how to standardize these data, especially for large studies that, you know, large prospective studies that have been going on for years. So definitely a challenge, but that's like one of the main goals, to make it computable.
Yeah, I mean, either in clinical trials, like still like the eligibility criteria are sometimes not even like standardized. It's like free text. And so like if we don't start like with like basic stuff, like how to progress, but it's like so many challenges, but I think it's like on the table of many persons. Yeah, excellent question.
Hi, thank you for the presentation. I'm working in the Medical Informatics Initiative in Germany, so that question is related to that. How would your model translate to like research on secondary use of routine data?
So we did try to align to the Medical Informatics Initiative. So especially when we were profiling study, like, you know, you have a profiled research study as well. But we do have to say we're much more extensive because the MII initiative is mainly focused on clinical routine data. And we definitely cover that. But then it's like much more extended with the public health and epidemiological. But we also are like in very close cooperation for the next funding phase. It's even one use case to align with that and also use the secondary data.
Excellent presentation. And this question again is related to the Medical Informatics Initiative. And I'm from MedBlocks, and we've been working with the HIMED group for COVID-related data and secondary use of that. And in the presentation, I noticed that although you use a lot of FHIR resources, a lot of what you've modeled are either logical models or extensions on top of the existing FHIR standard. So why not, have you looked at aligning with maybe another standard? For example, like some of your colleagues are using OpenAir to represent research data, and then mapping it out to FHIR to then like be compatible with the rest of the Medical Informatics Initiative. So here, what's your strategy here?
Yeah, so we know you guys are using OpenEHR, and I think it's always a debate what to use, but we're trying not to be only like looking nationally at Germany, but also like, you know, EU-wide, and like it just came out like the EU wants to use Fire, and the EHDS also, is looking towards Fire, and that's why it's our main focus. Does mean like when we're adding new use cases and we see we cannot, we need something else, like for example, just one new quiz where we want to try out OMOP or something, we'll definitely do that, but Fire will be the groundwork because of the international regulations also.
Yeah. And also it makes possible also to connect maybe like to medical devices, systems, EHRs and so on, like if you want then like primary data also like to be used like in research. So it's like several aspects that we are trying to encompass, but excellent question. We are always looking also to mappings to other standards and formats to make it computable.
One last question.
Thank you for your presentation as well. Have you interacted with or are you aware of the Vulkan Fire Accelerator? Okay, great. So especially bringing up the topic of structured eligibility criteria. So the M11, okay, you're aware of the whole structured protocol effort. Are you interacting with them in any way, just sort of?
Not enough yet.
Okay. I mean, they're just getting launched.
Yeah,
anyway,
exactly. So I met them also like at the working group meetings in Dallas. So we are trying now like to connect all the dots. But we already like discussed several things about the structured documents, and where was also EBM on Fire in close contact. So yeah, connecting the dots.
Perfect.
But thank you for bringing this up, because like that's one of the use cases also for the second funding phase.
Yeah.
Okay, thank you. No more questions. Then I would like to thank you for your presentation.
Thanks.